Thanks, Corey. And thanks again for inviting me to come to New York and give a talk on my favorite subject, which is stage 1 lung cancer and SBRT. I'm not so happy about having to follow Dr. Silvestri. That's a tough act to follow. He's a very good speaker, and I always learn quite a bit. Hopefully, I can attempt to match his presentation. I have no financial relationships to disclose. Corey mentioned that I had the lung cancer committee within our NRG, and I do receive a stipend, though I assure you it does not match the travel funds that are required to do the job. Let's start with a case. I had a patient referred to me by our surgeon, Brian Myers, who was seen by a cardiologist, and the guy had coronary artery disease and they put a drug-eluting stent. And he was on Cipragel, or clopidogrel. And a PET, they had detected a pulmonary nodule on an X-ray, and a PET detected increased FTG uptake with a max SUV of 2.5, which is right on the border of being concerned. So they did a needle biopsy, and it showed a squamous cell cancer. And they did PFTs, and he had an FEV1 that was high, and all his PFTs were good, and he was technically a surgical candidate, but he was on this drug-eluting stent and Plavix. And so, lo and behold, our surgeon sent him to me for SBRT. Strange, because he thought, I'd have to wait 6 months this guy's on Plavix, I don't want to operate on him. Let's give SBRT and let's see what happens. If it doesn't work, I can operate on him later. So I treated this guy with radiation. This is his lesion. The orange is what we treat with SBRT, our target. And this is last year's images. This is 5-year follow-up, 6-year follow-up now. It looks like this, what you see on the right. There's some scar tissue. That's a whole other lecture. What you see after SBRT, a lot of radiologists might call this recurrence or persistent disease, but no, if you treat a healthy lung with radiation therapy, you're going to get scar tissue. And so we just follow it, and it's been 6 years now, and he's doing well, never required surgery. So stage 1 lung cancer has been treated by surgery. I think almost every speaker has mentioned surgery for these patients, and rightly so, for the medically operable group. But if you break patients down into their groups, there's borderline medically operable patients. Most of those patients still get surgery. Maybe they get a lesser surgery like a sublobar resection, such as a segmentectomy or a wedge resection. There's increasing numbers of patients that are medically inoperable, I think because many, the CT screening phenomena, and also physicians holding on to patients with lung nodules that are cancer. We're seeing more of those medically inoperable patients, and we're delivering radiation, SBRT. I no longer give fractionated radiation therapy for stage 1 lung cancer. What I mean is like 30, 33 fractions. I don't do that anymore. We just give SBRT. And then there are the folks that nobody would touch with a 10-foot pole that sometimes we treat and sometimes we watch. Where are those lines? That's kind of where they are, where they stand today, although I think we're seeing more borderline medically operable patients convert to the SBRT arena, and I'll show you some data as to why I think that's occurring. First, let's talk about surgery. I think the best surgical data comes from our staging system, the AJCC 7th edition, where they collected over 100,000 patients from 46 sources in 19 different countries, of which 2/3 had non-small cell lung cancer spanning a 10-year period. And then the most recent trial that recently was reported at ASCO, Z4032, where patients with stage 1 lung cancer were randomized to receive brachytherapy after their wedge resection versus nothing. So this is pathologic T1 to T3 disease based on our current staging system. So they're completely resected and node negative. And I like to show this to our residents. We don't do that well with lung surgery or with lung cancer, because you've got the best population, and at 5 years, something less than 2 centimeters is 77% 5-year survival, and it drops precipitously as those lesions get larger. And as you also notice, the longer you follow those patients, the more failures you get. So out at 10 years, the 10-year survival is about 50% in your best group, and it gets worse. And this is pathologic staging. in radiation oncology, we deal in the clinical world, like clinical staging, T1 to T3, and those are worse. At 5 years, the best possible patients, clinical T1 less than 2 centimeters, have a 53% 5-year survival rate. So there's lots of room to improve. Nevertheless, these serve as a marker for what you would want to achieve if you had an alternative therapy to surgery, okay? So there's our barometer for what would be equal to surgery. Probably the lead article was from the lung cancer study group dating back to 1995, comparing a pneumonectomy or a lobectomy to a sublobectomy, which was a segmentectomy or a wedge resection. And they reported the 5-year local recurrence rates for the lobectomy or pneumonectomy cases, 6%, and for the sublobectomy cases was 18%. Now, what's buried in the manuscript and not reported individually was whether this was a suture line recurrence in the wedge resection group or a nodal recurrence, and you can't find that data anywhere. But about 2/3 of those were nodal recurrences. So surgeons classify failure as either within the lobe or within the nodes that would have been resected, and they call that local failure, and it's 6 versus 18%. And this is why we prefer an anatomic resection, meaning a lobectomy or a pneumonectomy, and a wedge resection being 18%. Now, I'm showing you data that has been reported at ASCO, and maybe you didn't go to ASCO, but these are the data, and maybe it's easier to see on your computer screen. But this was the ACOSOG Z4032 trial, where they did wedge resections with or without brachytherapy. That they sutured brachytherapy seeds into the suture line, and there was no difference in local recurrence rate whether the patients got brachytherapy or not. The anti-local recurrence rate was 13% and 12% respectively. It did not impact survival. It did not impact local recurrence. And part of the reason is that the surgeons were asked to do touch preps on their margins. And if touch preps came back positive, the surgeons were allowed to go back and take more tissue. So when you give the surgeon a record that they have a positive margin, they get negative margins, then probably your adjuvant brachytherapy doesn't play a role. At any rate, the recurrence rate here, anti-local recurrence, is on the order of 14%. Now, I'm a radiation oncologist, and this thing that's been out on the horizon for about 10 years now in the United States, stereotactic body radiation therapy. It's not a particular piece of equipment. It is a type of radiation therapy delivery. The word stereotactic meaning precise positioning of the target volume in 3 dimensions. I would say even 4 dimensions with motion. It's become synonymous with high dose perfraction, and we'll discuss that later. And it encompasses a variety of different delivery techniques and equipment. And sometimes we get focused on equipment, but it's all these pieces of equipment can do the same thing. You should get the same results regardless of your piece of equipment. And I've tried to include all pieces of equipment here, but there are probably more than I can put on one slide. The best data for SBRT comes from RTOG0236. We reported this in JAMA in 2010. Bob Timmerman is the PI. We had 1 failure at 3 years within the planning target volume, which was the area that was irradiated, and another failure in the lobes. We had 2 lobar failures, resulting in a lobar control rate of 94%, and controlling the tumor we treated 98% of the time. And this has really set the standard for SBRT. This is kind of the results we expect. This was a 3-fraction regimen of, at the time, 20 gray each. Since we've gotten better dose calculation algorithms now, it's 18 gray per fraction times 3, and that's pretty good results. Now, Corey asked for me to touch on thermal ablation for lung cancers, and I'm not an expert in this, but I am able to read the literature, and I'll show you what it says. The indications and contraindications for thermal ablation, inoperability, diameter less than 5 centimeters, a peripheral location because you have to reach it. Contraindications would be anything adjacent to a blood vessel or near the hilum, patient with coagulation disorders and a poor life expectancy. As you can see, This delivery technique will deliver a spherical dose distribution or a spherical heat dose distribution. It can't accommodate things that are abnormal or non-spherical unless you deliver 2 sequential or 3 sequential treatments. This is hard to read. It's a review paper that was from this year. There's more and more literature on this. It's up to 5 years of outcome now, but I want you to focus on the complication rate and the local recurrence rate. And maybe you can see that on your computers, but the complication rate ranges between 10 and 50%. And that's very high. And the local recurrence rate ranges in here from 17% to 57%. So it's not a great tool. It's not working very well. And we don't use it very often at our place unless maybe it's a recurrent patient who we've previously irradiated. But I'm not sure how much traction this has right now. As I said, the follow-up data are projecting 5-year results. Pneumothorax and chest drain rates are very high. Local recurrence rates are poor. I'm understanding that both industry and investigators are evaluating bronchoscopic ablation techniques. I'm not sure where we are with that. We consider it for SBRT failures, but I can't recommend RFA for first-line management. And by the way, neither does the FDA. So the gold standard for looking at surgery versus stereotactic radiation, because these things appear roughly equivalent, would be a randomized trial. And there have been several attempts at a randomized trial. In the Netherlands, they had a trial called the Roselle trial. It closed due to lack of accrual. It was about 2 years ago they closed it. Accuray CyberKnife ran a trial that's now closed. It was only for Accuray CyberKnife users. Jack Roth was the PI. He's at MD Anderson. It closed due to lack of accrual, but they had 30 patients on the study, and they did report the results. Although I don't have the results, I'm told they're intriguing, and they're await to be published, and they favor SBRT. For high-risk patients, which we can define what they are, but they had high-risk features of pulmonary function between 40th and 50th percentiles. ACOSOG, the American College of Surgeons Oncology Group, and RTOG combined to propose a randomized study which closed due to lack of accrual. We had tried to go through and put an amendment through for an institutional randomizations which the NCI did not agree with, and so that closed in May of this past year with only about 20 patients accrued to the study. There is a trial that may be one last hope. Maybe there's two. There's another trial in China, but the VA lung cancer group is trying to start a Valor trial, lobectomy versus SBRT, with the thought that the surgeons at the VA aren't paid based on their RVUs, that they don't really care whether they operate or send for radiation. So there might be more of a balance between whether they decide, well, you know, you could randomize a patient to surgery versus SBRT. So that's just getting off the ground. I was on the telephone a couple of times this week with Drew Maganaki, the PI. VA is starting to circulate this through their regulatory process, and we'll see where it goes. But this was the ACOSOG RTOG. This was for high-risk patients, sublobar resection, with or without brachytherapy or SBRT in 3 fractions. It was supposed to accrue 420 patients. It only accrued 20. I spent hundreds of hours on this myself. It's disappointing. I think it's hard to randomize a patient to say you're going to get a thoracotomy or you're not. It's very hard to accept that as a patient, and it's hard for a surgeon to sell that as well. These patients go to surgeons, and so trials like this have to go through surgeons. Just looking side-by-side comparisons, since we don't have randomized data to compare surgery to stereotactic radiation, what are the side-by-side comparisons? So the data on top is surgery, the AJCC, and if you just look at 3 and 5 year overall survivals for T1 and T2 disease, you can see them there as the markers of what the barometer, what we would measure against. And for SBRT, I just used the 0236 data. We combined T1 and T2 disease. So at 3 years, 71% for surgery versus 56% for SBRT, overall survival. And for T2s, you can see it there. The problem is that these two groups are not equivalent. In any of the data I show you from now on, they're apples and oranges. The patients come into my clinic on oxygen and in wheelchairs. They're not surgical candidates. So you comparing these groups and these data I'm going to show you, they're just different population data sets. And why? They have different pulmonary function, smoking, diabetes, cardiac comorbidities, performance status, they're all across the board. So for the Japanese have done a tremendous job looking at stage 1 lung cancer. The first trial reported for SBRT was from this guy Uematsu, and I won't show his data here, but he's looked at surgically operable patients he treated with SBRT. I'll show you some data from Onishi. It's a collection of 14 institutions. And then we've got some data from within the United States at Beaumont Hospital and our group at WashU, which we'll touch on here in a second. So if we look at the SBRT versus surgery from the Onishi data, again, he collected this data from 14 institutions in Japan and had a fairly lengthy median follow-up of 38 months. So all comers, the overall survival at 5 years in this publication for 257 patients was 47.2% and a cause-specific survival of 73%. And if you look at that overall survival by whether those patients were medically operable or not, the curves on the right, of course they do better if they're medically operable. So those are quite good, and you might think, that looks pretty similar to those curves Dr. Bradley showed me for the surgery group. The trick here is that you have to give enough dose with SBRT. So they published local control rates by dose, but whether they gave 100 gray or more biologically equivalent dose. And if you did that, your local recurrence rate was 8% versus if you didn't, it was on the order of 42%. So you've got to give enough dose. Now, what's enough dose? Using a BED calculation, we won't go through the formula. I hate it when our physicists do this to me, is go through formulas, so we won't do that. But if you just break it down, what gets you a BED greater than 100 is 3 fractions of 16 gray, 4 fractions of 12 gray, or 5 fractions of 10 gray. If you're not given at least that as the threshold, you're not given enough dose. And if you look at their data by dose, looking at greater than 100 gray, they give excellent survival, or looks like is as good as surgery, versus if they did less than 100 gray, they don't do as well. He's published an update from that in 2010, just looking at the medically operable patients, 87 of those treated with radiation alone without chemo, and these are the local control rates for 1A and 1B, a total local control rate of 86.7%, and the overall survival, 69.5%. You always want to double check your data. So if you take BED of 100 as a threshold based on the Japanese data, what is it in another database? So Electa makes linear accelerators, and Electa has a consortium of about 10 institutions that combine their data for SBRT, and lo and behold, if you gave a BED 10, the same formula I showed you before of greater than 105 gray, your local recurrence rate was very low. So here's a second data set with about 600 patients that says the same thing. You need to reach a BED of 100 gray or more. Now, Inga Grills at Beaumont Hospital looked back at their data, looking at wedge resection versus SBRT. And if you look at wedge resection, let's see if I go back here. If you look at wedge resection, local recurrence rates of wedge was 20% versus 4% with SBRT. If you look at local recurrence in total or overall survival, of course, the overall survival favors the surgical patients because they're healthier. We've published 3 papers on this. The latest one is from my colleague Cliff Robinson, who shares the lung cancer service with me, and I'm just showing you the curves from the paper, local control, primary tumor control, regional control, and cancer-specific survival in our population as we select them for these treatments is the same. But surgical patients have a better overall survival, clearly. But if you look at other barometers, it looks like these populations are quite similar in terms of local control, regional control, and cancer-specific survival. Another splash that occurred recently at ASCO and also the IASLC meeting, the RTOG reported the results of 0915. This was a randomized phase 2 trial that looked at 1 fraction of SBRT of 34 gray versus 4 fractions of SBRT, 12 gray each. And the primary endpoint of the study was toxicity, and these two, at least at 1 year, the toxicity rates are the same, and also the overall survival rates are the same and the local control rates are the same. So it's raised a question within the radiation therapy community, can we use 1 fraction instead of 3 or 4? And perhaps we can, but 1 year is not long enough to make a decision because these patients have recurrences beyond a year and toxicities occur beyond a year. Toxicities can occur up to 3 and 4 years after treatment. So it's too soon to make a change based on this, but this is intriguing data that at 1 year, 1 fraction appeared to do just as well. And as you know, in the brain, we use 1 fraction for brain metastasis. And if our technology gets good enough that we can hit the tumor, a mobile tumor in the lung with 1 fraction, we should get similar results. Centrally located lung cancers, these were separated out basically on a paper from Bob Timmerman from Indiana showing the higher toxicity rates with patients treated with central tumors. These are anything within 2 centimeters of a major bronchus or a blood vessel. And so we've been very careful about treating central tumors. The RTOG recently completed a phase 2 dose escalation study, 0813. Andrea Bizak was the PI. This was a study with continual reassessment monitoring. We started at level 1, 10 gray per fraction for 5 fractions, and we moved up to level 5, 12 gray per fraction for 5 fractions to a dose of 60 gray. Those data are maturing and haven't been reported yet. The trial's been completed. I will say there's something to treating central tumors. There's some toxicity. We did have 2 deaths on this study from massive hemoptysis. One occurred at 10.5 gray and another occurred at 11 gray. So there is something to treating central disease that you want to be careful about. Yet we only, out of 120 patients, we had 2 deaths. So that's not terrible. And this is to show why we started at 10 gray times 5. We had done a data analysis of our patients at WashU, and I started treating central tumors at 9 gray per fraction for 5 fractions, and we weren't doing very well, so I upped it to 10 gray per fraction, and it looks like we were doing as well as we were with our 3 fraction technique of 18 gray. Another measure to say give more than 100 gray per fraction. So in summary, I still think surgery is the gold standard for operable patients, although for inoperable and increasingly patients you consider that are marginally operable with stage 1 lung cancer, SBRT offers excellent local control, and it looks like similar overall survival. The SBRT results will be similar regardless of the delivery device. Differences in methods and imaging, whether you need fiducials or not, the overall treatment time, there's lots of differences that are brought in by the technology, but the overall outcome is going to be similar. And randomized trials have failed to accrue for various reasons that I touched on, and we're hopeful that maybe the VA trial can answer that question. Thank you.